Hey podcast listeners, welcome back to another installment of the Brainwaves Podcast, a show about neurology and medicine and all the fascinating science and history that comes with it. In our last program, Dr. Joe and I discussed how solving one problem only led to another, how organ transplantation increases one's risk of not only the various community-acquired infections out there, but also atypical infections, certain fungal diseases, viruses, and even rabies.
We actually had a case of rabies in Philadelphia this past summer, entirely unrelated to an organ transplant.
Luckily, there have only been a handful of rabies cases in patients who have been fortunate enough to receive an organ transplant. More commonly, the neurologic complications are non-infectious, encephalopathy, seizures, strokes. It's almost bread and butter neurology at that point. But it's not as simple as you might think. To give us some clinical insight into these other complications, you'll hear from Dr. Raj Dhar, a neurointensivist from Washington University in St. Louis, who's written extensively on the subject. And hopefully, after this two-part series, you'll be able to better evaluate these complications in your own clinical practice. Stay with us. I first started the interview curious how Dr. Dar, who's published on some of the various neurologic complications of transplantation, what was it that initially drew him to the field? You've written a lot about this, and what was it that got you interested in the topic?
Well, it was actually at first, as a resident in neurology, I was always drawn to the sickest and most medically complex patients. And of course, that's the reason I chose neurocritical care as a career. And so training in neurology in Canada at a large transplant center, I happened to get a fair bit of experience consulting on transplant patients who had neurological issues. And through collaboration with our transplant surgeons, my first research project as a young resident was looking at the incidence of these neurological complications after liver transplant in particular. And so
I pulled the paper he wrote on this, published in Neurocritical Care in 2008, a single-center study examining these post-operative neurologic complications. And the strongest predictor of neurologic morbidity within 30 days was uncontrolled preoperative hepatic encephalopathy.
It was really a nice example of the complex milieu of how systemic changes can affect the brain, whether it be with seizures.
Not surprisingly, from his 101 patient cohort, 31% of patients had some sort of neurologic complication following transplantation, 1 out of every 3 patients. The most common complication was encephalopathy, again, which was strongly tied to preoperative hepatic encephalopathy. And this was seen in almost every patient who had a complication. But drug toxicity was also common, accounting for 39% of the neurologic complications after liver transplant.
Yeah, I think it's something that we're going to see as neurologists most commonly, although not exclusively, in the postoperative period after a transplant.
Like I think we mentioned in the previous show with Dr. Joe, the majority of transplant complications occurred soon after surgery.
One other thing is that the incidence of complications may have also gone down over time as they've become more recognized as complications of the transplant and drug-related interactions that are going on in that period. The incidence of complications later are much less. You're going to see those patients sporadically come back to see a neurologist or be admitted with a neurological problem in the weeks to months afterwards. I think both are relevant and interesting. Probably more upfront is what we see, but in my research and reading, there's definitely a growing amount of delayed complications, especially as transplant patients are living much longer than they used to. In fact, neurological complications are, in that respect, maybe becoming more common in the delayed period.
Yeah, and before we get to those here, I'll jump in and say that the neurologic manifestations of transplant complications can be broken down into 2 groups. Anyone who's worked in a hospital can attest to this. First, there can be primarily neurologic problems. The issue at hand is a problem in the brain. And second, there can be systemic problems that manifest with neurologic dysfunction, like the organ graft is failing. And teasing these two apart can be very difficult early on.
Groups, and that is probably the first dichotomy, is whether the organ is working or not.
Meaning transplant rejection.
Thankfully, that's relatively rare. In my experience, that accounts for the minority of neurological complications.
And usually those are pretty easy to recognize on routine laboratory tests. And often these people are pretty sick to begin with, and they're already in the ICU.
It's probably, in my experience, more the patient who is otherwise doing well, where the organ is working, but then develops complications that poses more of the challenge for the neurologist.
And this segues nicely into the next tier of your approach to any patient who's had a transplant complication. They've made it through the surgery, no immediate post-operative complications, surgical site infections, hemodynamic instability, strokes, and so on. You know the organ graft is functioning well. And then, after several weeks or maybe a few months, something changes. There's a neurologic event. You think to yourself, it could just be like any neurologic event of its kind, and maybe it's unrelated to the transplant. A seizure, a stroke, peripheral neuropathy. Or maybe is it a consequence of the transplant? And now you have to worry, is it possibly infectious, or isn't it, as we discussed with Dr. Zhou before? Or is it a medication side effect? How do you conceptualize the various medications that our organ transplant recipients receive and what those medications can do to the nervous system?
Yeah, I think that's a good way to look at it, is to understand the classes that are used. And there seems to be a fairly typical pattern, although it does vary by organ. Obviously, all patients receive corticosteroids.
Fast-acting immunosuppressants.
That's been, around for 50 years or more.
And are still drugs fraught with the risk of agitation, tremor, and hyperglycemia in the short term, and opportunistic infections and myopathy over the long term.
But the real revolution was the advent of the so-called calcineurin inhibitors.
The first one being cyclosporin.
And then more recently, tacrolimus.
And even more recently, sirolimus and everolimus, which are actually mTOR inhibitors, so they've got a different side effect profile from TAC, as we'll get into.
Those are almost ubiquitously used in addition to steroids, and those form both a revolution for the success of transplants, but also have perhaps the greatest potential for toxicity.
Namely, for tacrolimus, we think about action tremor, akinetic mutism, headache, or PRESS, the posterior reversible encephalopathy syndrome, whose risk increases when there are toxic levels of TAC, or when there's kidney dysfunction, or hypertension, sepsis, or even a combination of these things. And in addition to this class of drugs, there are also cytotoxic drugs like muronimab or OKT3.
OKT3, which is an antibody that can cause headache and aseptic meningitis very commonly. And so we need to be aware of these early agents that can cause patients who are otherwise doing well to have neurological symptoms like headache and even have a meningeal picture.
I think it's also easy to conceptualize these complications as being early complications and maybe more delayed complications. So of the solid organ transplant complications that affect the nervous system, how do you kind of categorize these complications by timing from the transplant?
I think the easiest way is to look at early being technically, it would probably be anywhere in those 30 days after transplant. And the reason that's helpful is that early period is a time of high risk for neurological complications, but also it's a time when specific things like drug toxicity are especially common. And that's largely because, one, you're having more drugs given in that period, including induction agents, but also sometimes loading doses of the calcineurin inhibitors and steroids. So the early period is really a high risk period. It's a period when drug toxicity is particularly prevalent. And also, of course, the metabolic and organ-related problems tend to happen in that time period, where if the graft is not working or there's, concomitant renal dysfunction from medications or from hypotension, that can cause encephalopathy, for example.
So early period, high-risk systemic infections, metabolic derangements, drug toxicities.
Prevalent. While later, beyond 30 days, they're at risk for a different type of complication. Drug toxicity can occur, but it's less common, as are metabolic and graft failure, of course. But you have a higher risk for more prolonged consequences of immunosuppression.
Like opportunistic CNS infections or CNS malignancies.
Are things you would think about in the months to years after transplantation.
So in this later phase of transplantation, say a patient comes into your hospital and presents with seizures. Now, when I think about a patient who has their first ever unprovoked seizure of life, usually you don't initiate anti-epileptic therapy unless there's something that's more concerning that raises your suspicion that they're going to have more events, like they have a focal lesion or they've got something on the EEG. Now, this is not the same for organ transplant recipients. If they've got a seizure, you've got to be a lot more concerned. So, how does the transplant process inform how you would address these patients, how you manage these patients?
I think certainly the breadth of causes of seizures is quite extensive and can be intimidating, but I think it still breaks down into the reversible metabolic and drug-related causes of seizures, which again occur more in the early period. And the prognosis is quite good. And in fact, in that case, anti-epileptics beyond that acute period may not be warranted.
You treat the underlying cause, and then seizures can be prevented moving forward.
However, in the delayed period, as you describe, when a patient comes in after transplant with a seizure or with really any even non-specific symptom, you really have to worry about some quite subtle neurological process that may be heralded by the seizure. And the most common one of those would be an infection, which can occur even in the absence of a fever,
which we discussed with Dr. Zhou previously.
But also a number of chronic diseases like a malignancy, lymphoma, or progressive multifocal leukoencephalopathy, or PML, which is, of course, related to an infection, but can present with white matter disease. So the types of things that cause seizures are different in that delayed period, and certainly it warrants a very careful workup, including MRI, lumbar puncture, to evaluate a patient after a transplant with a seizure.
Is your threshold to image and to get EEG, is that lower than your average patient?
I think so. I think it's fair to say that, especially in that delayed period, you have to have a very low threshold to fully work up any patient with neurological symptoms because the presentations may be attenuated by the immunosuppression.
These patients may just look less sick. They could be harboring a massive brain lesion or severe meningitis, and you'll never know it, which is why we always get imaging before the LP in these patients.
It's probably not often that I've seen a lumbar puncture done before at least routine brain imaging, even if it's not an MRI, but a head CT.
And their imaging won't be exactly what you expect either. For example, in patients with post-transplant lymphoproliferative disorder, the confluent enhancement pattern may be less pronounced, or it could be ring-like.
Certainly the enhancement pattern in the presence of severe immunosuppression is less conspicuous.
Patients with CNS aspergillosis or abscesses may also have less surrounding vasogenic edema, stuff like that.
Even if you do image, may be less obvious, but also things like fever and pleocytosis and all the typical findings of a process that is going on may be more subtle in these kind of patients. So it's really unlikely that a seizure after transplant is benign in that period, and it does really require a thorough workup.
In a patient who comes in with a clearly drug-induced neurologic problem, somebody who has NSAID-associated aseptic meningitis, it's easy in those situations to say, okay, we need to discontinue any further use of NSAIDs because it's obviously resulted in this significant neurologic event. But in patients who have, cyclosporin or tacrolimus-associated press or other complications, it's not as easy to say you have to stop your immunosuppression. You need it for your organ transplant. What do you do in those situations kind of in the acute setting, and then how are these patients kind of managed in the long term? When do we, reinitiate therapy, or when can we move on to alternative therapies?
Yeah, the issue of drug toxicity and what to do about it is certainly a difficult issue, and making sure that you feel confident in the drug toxicity.
For example, was that liver transplant patient's subrectal hemorrhage related to tacrolimus-associated press? Or was it related to coagulopathy from hepatic insufficiency?
And then certainly the acute management involves either discontinuing or holding the medication, or the other thing that has happened I've seen is if clearly the dose was elevated.
Maybe the tacrolimus level was twice what was expected.
Sometimes if it's a not life-threatening complication, meaning just headaches or tremor, or maybe mild press, if that can be, conceived, then I've seen dose reduction while still continuing the offending agent as an option. That's not all the time.
Meaning this, do you as the physician believe that either the side effect was truly benign and the patient does not find it functionally impairing, or if the side effect were slightly more serious, do you feel confident enough that you can work with the patient to maintain the serum levels in a safe and effective range moving forward?
Of course, there are times, and often when we see those patients, it's more severe where they have seizures and more severe press. And in those cases, we would recommend holding the cyclosporin or tacrolimus. And then once the syndrome has resolved, which can take days, but often a week or more, then your options are threefold. One, if you felt it was due to aggressive dosing, to re-challenge at a much more cautious dosing of the same agent.
Okay, you restart the drug once levels return to a safe and therapeutic range and monitor closely.
I would say that's not so common in my experience, but I think that's one option. One is trying an alternative agent.
Like switching someone from tacrolimus to sirolimus, which carries a lower risk of press.
And that's what I see happen the most often, is simply re-challenging with a different agent once the symptoms have clearly abated.
And obviously, you'll be doing this under close monitoring and with the explicit approval of the patient's primary transplant team. Going along that same line, in situations where it's not so clear that a medication is producing a toxic effect, but it is a medication that you do see that's associated with that neurologic consequence. Say somebody's on asparaginase for induction, and then they have a venous sinus thrombosis, and they have seizures, and now they have hemorrhages as a complication of that, but they're also in DIC because they're immediately post-transplant and they're septic. It's hard to draw the line sometimes and say it's that drug or it's not. And how do you go about having that conversation with the organ transplant team and the rest of the ICU team and the patient about, well, it's not so clear, or it's more clearly going to be this or the other?
Yeah, I think you mentioned the conversation, and of course that's a critical component, that this is a really big team, probably bigger teams than we as neurologists are often used to, meaning there's a transplant surgeon, there's often a transplant physician, there's obviously the patient, the family. So definitely that conversation comes in very handy. And obviously they've been following the patient quite closely, so they're also actually quite helpful to tell you the time course of these symptoms if that's in question. I think you obviously have to decide to what degree this medication may be contributing. And I think in the case of calcineurin inhibitors, I found it easier because that's where imaging can be helpful nowadays. With MRI, there's not much else in that metabolic picture, although certainly press can occur from other things. If you see changes that are concerning for press, even if they have sepsis and DIC, which could be contributing, I think you have to assume, given that that's a very high risk medication for that syndrome, that it could at least be largely contributing.
You can think about other medications the same way. Mycophenolate mofetil, which is used in kidney transplants, not uncommonly causes or it exacerbates headache and dizziness. But how much of this can we really attribute to the mycophenolate? And how much of this is a consequence of hydration status or comorbid vascular disease? Besides conceptualizing these complications by the timing of onset, or the specific medication classes, or maybe the particular MRI findings that can affect the organ transplant population, you might also think about which disorders are more likely to affect specific populations of transplant recipients.
There are specific complications, at least we need to think about, that are unique or certainly more likely with certain transplants.
For example, intracranial hypertension,
especially liver transplant recipients.
Or immediately after liver transplant, the risk of osmotic demyelination.
There's often a large correction of the hyponatremia that cirrhotic patients have.
And these fluid shifts can cause myelinolysis. Then there's Wernicke's encephalopathy following gut or liver transplant.
Because of the malnutrition that people with intestinal malabsorption have, and then the sudden resumption of intestinal function after transplant.
Now these patients are all of a sudden absorbing more carbohydrates, and they can rapidly deplete any of the remaining thiamine stores.
That's one that's fairly unique to intestinal transplant.
Or you can imagine in patients with heart or lung transplant,
the chances of having a mass lesion are a little bit higher.
In particular, toxoplasmosis following heart transplant, which likes to hide its cysts in the transplanted heart muscle.
And of course, anatomical injuries are unique to each transplant.
So you can imagine the physical risks of surgery, given the particular region of the body that's involved.
Heart and lung transplants tend to have risk of phrenic nerve injury,
while renal transplants carry a slight increased risk of injury to the femoral nerve or the lumbosacral plexus, and so on. What should our listeners take away from our discussion today?
I think the main lesson that I've learned from reviewing patients after transplantation is that we need to be vigilant for neurological complications. They can be subtle, from headache, paresthesias, tremor, or they can manifest abruptly with a seizure. But most importantly, we have to recognize which ones are reversible, likely drug toxicities, treatable infections, and work those up appropriately. And so I think that's where I really see the neurologist being critical, is being able to take that away to say, appropriately work out this patient and to separate out those reversible causes that are often drug or metabolic from the catastrophic causes.
And not only can the neurologist be helpful in working up the complications following organ transplantation, but the fact that many systemic problems manifest with neurologic dysfunction make us, as neurologists, very useful in the pre-transplant process. As transplant medicine becomes more sophisticated, and these patients are living longer and fuller lives, we may be able to contribute to the care of patients awaiting transplant, and maybe even guide the transplant team on which patients may be good candidates, despite how neurologically impaired they may seem, especially among patients with liver failure.
Some patients who have very severe neurological complications before transplantation as a result of acute liver failure, where often you can get severe cerebral edema, raised intracranial pressure, seizures, and it can be a really life-threatening scenario. What I've seen in some of my experience in my research is that if those patients undergo liver transplantation in that case, I was surprised to see the really dramatic improvements that they can make. And I think it's worth stressing that we shouldn't give up on those patients if we're consulted on them before transplantation, that in fact, those patients, often younger patients, whether it be acetaminophen overdoses, other etiologies, they can really make not only good liver recoveries, but have quite dramatic neurological improvement, and often had the lowest incidence in my experience of complications after transplant, even though they were the sickest before transplant.
Raj Dhar, thank you so much for being on the podcast.
It's my pleasure. Thank you for having me.
All right, take care.
Yeah, no problem. Have a good day.
And a huge thanks out there to everyone who has contributed to our knowledge of transplant medicine, all the physicians, the scientists, and all the patients who've given their lives in the pursuit of this medical achievement. For the listeners out there, if you learned anything at all, take a moment to rate the program on Apple Podcasts, Stitcher, Google Play, or wherever you get your podcasts. The program this week was produced out of Studio 3 in Philadelphia, Pennsylvania, and it was produced by myself, Jim Siegler, and Raj Dhar. Music was courtesy of Steve Coombs, Lee Rosevere, and Scott Holmes. Sound effects by Daniel Simeon and Mike Koenig under a Creative Commons license. I'm Jim Siegler. Talk to you soon.